about a few more minutes while people join, and then we'll get started. I put the pre-test link in the chat. You guys want to go ahead and take our pre-test really quick in the chat, and then at the end of the session, I'll put the post-test and the evaluation in the chat as well. So a few housekeeping issues, please have everybody muted. I think everybody should be muted when they join, but go ahead and if you for some reason are off mute yourself. We do like seeing faces, so if you are able to have your camera on, that's great, but I also understand people have internet issues and maybe at lunch and not necessarily able, but if you can, great. I will be monitoring the chat and keeping an eye on things, so if you do have a question during the session, you can either take yourself off mute and ask the question yourself at an appropriate time. We do try to make this as like a discussion interactive, so don't feel like you can't. Dr. Hinkie is more than happy to answer questions. It's why she's here doing this. Or you can type the questions in the chat, and then I will, bring them to Dr. Hinkie's attention and ask them as that piece. So those are either of your ways of doing it that you can ask. So, and then the final thing is that I will say is if you could go ahead and put in the chat as well, your name and who, like what agency or organization you're with, that would be great. And with that, I'm going to turn it over to Dr. Missy Hinkie today to share with us this wonderful information. I have heard her speak on this numerous times before, but I can always hear her speak on it again. So, because I think she does such a wonderful job. I really think that medication-assisted treatment wouldn't be where it is today in this state without her valiant effort. So thank you. We appreciate that. So with that, I'm going to turn it over to you.
All right. That's a lot of pressure. Just kidding. We're good. So yes, I am Missy Hinkie. I am the medical director of the Heartview Foundation in Bismarck and Candu, soon to be Dickinson. And I also am the medical director for the North Dakota Professional Health Program, where we work with physicians, PAs, and medical students who struggle with substance use disorders and mental illness. So basically today we're just going to do an introduction to, I'm so distracted by finding out where all of you guys are from. Like, oh, this is exciting. So we're going to do this. Let me see here. All right. So our basic objectives, we're going to discuss how the limbic system and dopamine play a role with substance use disorders. And then we're going to talk about medications for opioid use disorders, the benefits, as well as some of the different meds. And just for some language, some verbiage stuff, medication-assisted treatment is using meds to help, it's kind of that full court press, using meds in combination with counseling and social supports to help someone manage their substance use disorder. An offshoot of that is medications for opioid use disorder. So you can have MAT for alcohol, for nicotine. MOUD is specific to opioid use disorder. So that's really what we're going to talk about today. Here's our basic outline, Addiction 101, because I just think that most of us work in the field, but I think it's always nice to just kind of have a review of what that looks like. We're going to talk about how opioids are different, specifically with mortality, talk a little bit about recovery, and then MOUD and the impact that it has. So the limbic system is the part of our brain that contains our reward circuitry. So this is the specific area of our brain, which includes the amygdala, hypothalamus, prefrontal cortex, the cerebellum, hippocampus. All those pieces aren't that important, but just to know that like this is the interior of our brain. We're all hardwired the same. When I talk to docs and PAs, I always say, you know what, our brains aren't any different than anyone else. So we are subject to the same hijacking as everyone else when it comes to our limbic system. Responsible for how we perceive things, both positive and negative. And I like to use these slides because my kids are 17, 15, and 11. They can identify this as 9/11. But I always tell them, I feel these slides. When I see these images, I remember where I was, how I felt, what happened, the fear, the anger, all of those things, because my limbic system takes sights, sounds, smells, ties it to memories and ties it to emotions. It's why if you hear a song that takes you back to your childhood, you remember the things that you were doing with that song, how it felt, all of those things. Or if you know, let's say, like for me, my grandpa used to fry walleye every Saturday morning for breakfast. He died when I was 12. If I smell fried fish, I immediately am taken back to my grandpa and the memories that we had on Saturday mornings. And I'm 47 now, so it's been 35 years, and that's still how my limbic system is hardwired. And so that's how important those memories are. That's how important our system is. It controls and regulates our ability to feel pleasure, which motivates us to repeat the behaviors that we need to survive. What that means is that eating, drinking, sex, those things are hardwired to feel good, because if we didn't do them, our species wouldn't survive, right? And when you look at people who have dementia, they forget to eat, right? So part of our limbic system is tied into memory, right? So as we start losing our memory, we lose the ability to recognize that this is a life-sustaining activity that has to happen. Drugs of abuse hijack this system with dopamine. Dopamine is a great neurochemical with lots of different purposes. So it regulates movement, emotion, motivation, and feelings of pleasure. So dopamine is the primary neurotransmitter with Parkinson's disease. So if you ever see someone with a Parkinson's tremor, it's this very specific pill rolling tremor. It doesn't look like this. It's more like this. That's not enough dopamine, right? If you see someone with Parkinson's, once their meds kick in, sometimes they get these really big, we call them choreoathetoid movements. That's too much dopamine. What we're going to focus on isn't so much the movement piece of dopamine, but the feelings of pleasure. So what happens is drugs of abuse target our reward system in our limbic system by flooding it with dopamine. And dopamine is very much a feel-good chemical. So when we get that dopamine, we get this huge euphoric effect. And again, that triggers our limbic system to create a memory, and it's a very positive memory. So it teaches us to repeat that behavior, just like eating, right? Like, or let's say you're mowing the lawn, it's 105 degrees, you get done mowing, and you go and you have a big glass of ice water, that immediate, like, oh, that was amazing, right? So that hopefully the next time you mow the lawn, you don't actually let yourself get that thirsty, but we get a little bit of euphoria, triggers a memory so that we repeat that behavior. So when we talk about dopamine levels, sitting here right now, we probably have about 50 nanograms per deciliter. Look at what substances do to that though. Marijuana, heroin, methamphetamine. So meth will take that to almost more than 20 times normal. So again, what happens is, sitting here at 50, I use meth. I get this bath of dopamine in my limbic system, which creates this euphoric effect, creating this memory so that I want to do it again, right? Because this is the chasing the dragon effect. This is the I want that feeling again effect. Now, as our brain continues to be exposed to these high levels of dopamine, right? I've got all this dopamine running around in my brain. So my brain is going to create less dopamine because there's an abundance, right? Like when we have an abundance of something, we generally don't make more of it. And I also am going to down regulate the number of receptors in my limbic system because it's stimulating, right? So then what happens if you take away the meth or the heroin, I don't go back to 50. I may go to 30 or 20 or 10. And if dopamine is my feel-good chemical, I don't feel good. So then my limbic system says to me, hey, Missy, you know what would feel better than this? Probably heroin, right? Because it's going to remind me like, hey, remember that, how great heroin felt? So it pulls me back into that so that I want to replace that dopamine. Now, no addict is going to tell you like, oh, I'm just trying to replace my dopamine. But physiologically, that is what is happening at that level, is they're trying to replace their dopamine because they don't feel good without it. So the withdrawal from any substance is the opposite of the intoxicating effect. So what that means is if I'm an opiate user and opiates are down, right? So what happens when I'm intoxicated on opiates? Well, my respiratory rate slows down, my heart rate slows down, I'm constipated, I have dry eyes, dry mouth, lethargic, all of these things. If you take the opiates away, then I'm going to have agitation, anxiety, watery eyes, runny nose, yawning, sneezing, diarrhea, increased heart rate, all of this very uncomfortable symptoms, right? So that's the very physical opiate withdrawal. But once that goes away, let's say I'm incarcerated or I'm hospitalized or somehow I just white knuckle it through the worst of it, then there's this subacute opiate withdrawal that might last 6 to 9 months. And this is a dopamine depletion effect. So this is depression, lack of enjoyment, insomnia, fatigue, poor appetite, cravings, poor focus, sleep disturbance, all of these things. And this is related to that lack of dopamine. So when we talk about withdrawal, right, whether it's acute withdrawal or subacute withdrawal, the severity is what drives you back to using. So if I've been taking 5 milligrams of hydrocodone a day for 3 months, and then I stop, I might be a little bit like ick, but it's not going to be bad. But if I am using a gram of IV heroin a day and then I stop, my withdrawal is going to be miserable and it's going to last longer. And again, because I have that tolerance effect, and tolerance is basically needing more to get the same effect. So if I used to get high on 30 of OxyContin, and then all of a sudden I need 60 and 90 and 120, and then I switch to heroin, as my tolerance goes up, my withdrawal goes up, and I just keep increasing my dose. So again, the more I'm using, the worse my withdrawal, both the acute physical withdrawal as well as the subacute, more mental withdrawal. So when we talk about the opioid epidemic, it kind of comes in 3 ways, right? So it started out, and you can see it's the teal line, sort of the aquamarine color, was prescription pills. So this kind of started in the late 90s when we made pain a vital sign, which means that every time you go to the doctor, they're going to ask you about your pain. But about this same time, Purdue Pharmaceuticals branded OxyContin as a non-addictive pain medication, right? It was FDA approved as being non-habit forming, non-addictive. They told us that if you have pain, you don't get euphoria. And then we have pain being a vital sign, so it's always going to be addressed. So what happened was everyone that said they had pain got a prescription for something, right? So in 2012, we had 259 million prescriptions for pain pills in this country, which was enough for every American adult to have their own bottle. So 2012 was kind of the peak of prescribing, right? But then what happened is, as prescribers, we started cutting back, because it's like, okay, this is actually crazy how much we're prescribing. So we cut back, which is, supply and demand, basic economics. We had created a demand and we cut off the supply. So what happened was people switched to heroin, which is that royal blue line. And you can see that really started creeping up, and started in 2010, but really continued to escalate. Since that time, though, what we're really talking about is the synthetic opiates. So tramadol, fentanyl, anything that doesn't rely on the poppy plant, right? So it's made in a lab, the potency varies, all of those things. And that's that purple line. And you can see that since really 2014, that has really been spiking. So that's kind of what's driving the epidemic now, is this fentanyl. 50 to 100 times more potent than morphine. And again, in March of 2015, the DEA issued a nationwide alert identifying fentanyl as a threat to public health and safety. And between 2013 and 2019, overdose deaths involving fentanyl and fentanyl derivatives increased by more than 11-fold. And so what we have seen is just this uptick in fentanyl deaths. And this is actually per quarter. So if you look at it in 2011, we probably had about 300 people dying per quarter. You take that to 2016, where we had almost 6,000 people dying per quarter. That's a span of 5 years. And you can see what is happening there and why this is what is driving the opioid epidemic. So when we look at all opiates combined, whether it's prescription pills, heroin, or fentanyl, you can see from 1999, we were less than 10,000 people a year. 2020, we were at 68,630, right? So what happened with COVID? Well, if substance use is an illness of isolation, COVID certainly didn't do us any favors, right? Now, this is looking at all drug overdoses, not just opiates, but we know that opiates are 70 to 80%. So we went up 39% in 2 years to over 100,000 in 2021. So that means 70 to 80,000 of those people died of opioids, right? Like, not a very positive. 295 people die every day from a drug overdose. So when I started giving this talk about probably 9 years ago, I lectured to the patients that we have every month, and I would say, okay, you guys, someone dies every 20 minutes. So during this hour-long talk, 3 people will die. Now I have to say during this talk, 12 people will die. And that's in the span of, 8-9 years. We are 5% of the world's population. We get to claim 27% of the world's drug overdose deaths. So we're not doing something right. Looking at NIH, they reported more than 80,000 people died of a drug overdose in 2021. And again, the vast majority of that was fentanyl related. Compare that to 58,200 US troops during the 20 years of the Vietnam War. 43,000 people died due to HIV and AIDS during the peak of that epidemic in 1995. And almost 3,000 people died on the day of 9/11. We have a 9/11 about every week and a half, 2 weeks when it comes to drug overdose deaths. So, we have beautiful monuments to the people that died in the Vietnam War and 9/11. But largely the drug overdose deaths just get reported and forgotten about, even though we're talking about 80,000 people in one calendar year. But it is not just opioids. When you look at this graph, again, that bright orange line, that synthetics, we know that that's skyrocketing. We talked about that. But if you look at cocaine, which is a sort of banana yellow line, you can see that that is climbing up. Methamphetamine is that lighter blue line, that's also skyrocketing. When I was in med school in 1998, they told us that people don't die of methamphetamine overdoses. And now it looks like, 15,000 people probably did. Now, a lot of this is because their meth, their cocaine is laced with fentanyl. But you can see that absolutely it is all the substances that have become pretty lethal. I hope I have your attention because working in this field, clearly we have a lot of work to do. We are not making a ton of headway, it appears. Thank God we have a bunch of Narcan on the street, because otherwise that 80,000 would probably be closer to 500,000. Nobody really knows because we don't really track how often Narcan is used, because we just give it out and let people use it. But again, nobody really knows what that would be without the Narcan. So this is what we're really talking about, is recovery, right? It's a process through which an individual improves their health and wellness. They live a self-directed life and they strive to reach their full potential. It doesn't say how they do it, right? It doesn't say with or without meds. It doesn't say with or without treatment. It doesn't say they go to 90 and 90. It's a process, and everyone's process is a little bit different. And if a recovery were a pie, no two pies would be alike. If we sat down the 400 plus patients we have at Heartview right now and said, okay, I want you to draw a pie graph and I want you to put all of the important pieces of your recovery in there, however big or small you think they might be, we would have 400 different pies, right? Because everyone needs different things. We all need different tools in our tool chest. Some tools don't work for some people. Some tools really work for some people. And so part of my frustration is that there's a lot of talk about, well, you have to do this or you're not really sober, you have to do this, or if you do that, you're not really sober. And a lot of that is surrounding the conversation of medications for opioid use disorder. And again, I would argue there's room in your pie for MOUD or MAT if alcohol is your substance, right? So when we talk about medications for opioid use disorder, we talk about methadone, buprenorphine, naltrexone, and naloxone. Methadone is a long-acting synthetic opiate, meaning it is manufactured in the lab. It does not come from the poppy plant. Higher doses are more effective and good outcomes are contingent on length of treatment. So again, like this is our little opioid receptor, right? So if I use heroin or fentanyl, it binds to that receptor in such a way that it causes the downstream release of dopamine. That's what lights up the pleasure centers in our brain and keeps us coming back for more, right? How methadone acts is it binds in much the same way, but it binds really slowly and it binds really tight. So because it's coming in slow, you don't have that euphoric effect. And because it binds really tight, if you're taking your methadone every day and you use fentanyl or heroin on top of it, the methadone holds its place, so you don't get the same high that you were anticipating. So my patients will tell me it's kind of a waste of money because I know I'm not going to get that same feeling. It is only available through an opioid treatment program. We were the 49th state to get OTPs. In North Dakota, currently, we have OTPs in Minot, Bismarck, Fargo, and Grand Forks. Federal law requires that clients in an OTP are seen by a licensed addiction professional every single month. It also required 8 drug screens annually, and it is daily dosed out of an OTP. Take-home doses are earned based on compliance with these rules. Absence of recent drug use, coming in consistently, no behavior problems, no criminal activity, stable home environment, right? These things all seem pretty like attainable to some of us. But I will tell you, for some of our clients, these are not attainable. A stable home environment and social relationships is a bit of a stretch for some of our people. And you have to be able to make sure that your meds are stored safely. So again, the first 90 days, people can have 1 take home a week. So when people tell me like, oh, a methadone is a cop out, it's just the easy way out, I'm thinking, okay, our OTP is open from 6 till 8:45 in the morning. So 7 days a week, you need to be here before 8:45 in the morning or you don't get your meds. And then after, 180 days, then you get 2 take homes a week. And then after another, 90 days, you get 3. And then it's a year before you get a 2-week supply. And again, you still have to meet all these criteria. It's 2 years before you get a month's worth of meds. And that's if you meet these criteria. So it requires a significant commitment. If you want to go out of town for the weekend and you don't have take homes, you need to have that planned so that my nurses know, so we can arrange guest dosing or get permission for take homes. I mean, it is a very laborious process. But does it work? Well, here's some HeartView data from February of last year. If you look at employment rates, it was almost double from baseline to 1-year follow-up. Look at the mental health though. At baseline, 47% reported poor to fair mental health. A year later, it was 24%, so almost dropped in half. Arrested went from 90% lifetime with an average of 10 arrests to 4% in the past month. Injected drugs went from 84% to 9%. Overdoses, 61% to about 0.8%. That sounds like a life-saving intervention, right? How about treated in the last month in the ER for alcohol or drugs? Almost half at baseline, and then it was down to 3%. So if you don't even care about people and all you care about is dollar bills, this saves dollar bills, right? This saves taxpayer money, this saves insurance money. And again, you look at the top, how many have HIV, how many have hepatitis C, violence or trauma. And I think 65% is a gross underreporting, because I always think probably 90% of our patients have experienced violence or trauma. They just may not feel like reporting that at baseline because they don't necessarily trust us with that information just yet. So that was methadone. Switching gears to buprenorphine. Subutex is buprenorphine alone. Suboxone combines buprenorphine with naloxone. And again, the naloxone is only in there to prevent you from shooting it up. It is not in there for any other reason. So, and when we look at how, like, here's our opiate receptor again, right? So fentanyl and heroin do this. Buprenorphine kind of half sits on the receptor. So you don't have cravings, you don't have withdrawal, but other opiates can't bind. So if you're taking your buprenorphine appropriately and you use on top of it, you will not get the same high. Sublocade is a relatively recent intervention. Basically, you stabilize someone on Suboxone for about a week, and then they can come in and get a once-a-month injection of just buprenorphine, and then it just slowly leaches out of their system. So they would do it every month for a period of time, and then, you know, forever if they want. But we don't have to worry about diversion. We don't have to worry about any of that because it's injected into them. FDA approved in October of 2002. Again, a partial agonist, so it binds a little differently. Lower risk of abuse, addiction, and side effects. Again, it can go under your tongue. It can be injected into your skin. It can be surgically implanted into your arm. I don't know anyone that does the intradermal, but I know that it is available. And again, very safe, no organ damage. Heavily regulated by the FDA. Recently, the rules changed. It used to be that as a provider who wanted to prescribe this medication, I had to take a special training course. I had to register with the DEA. I had to jump through all of these hoops, which then gives the impression that this isn't a safe medication, right? Because I don't have to take any special training to prescribe Xanax or fentanyl or Oxycontin. But if I want to prescribe this, I have special training. So it kind of led prescribers to believe this must be dangerous or high risk or something like that. They just changed the rules this year so that you don't need those things. You don't need an X waiver. You don't need special training, which is great. It should increase access to these medications. So when we talk about, you know, because I hear all the time, oh, people on Suboxone, they're still high. People just take their methadone because they want to get high. Well, they've done studies, and we talked about 50 nanograms per deciliter of dopamine is normal, right? Buprenorphine and methadone both raise dopamine to normal levels of 40 to 60. People with low dopamine levels have extremely low retention rates for treatment. Less than 10% will stay in treatment because they feel miserable, right? Like they're like, okay, I'm ready to give up the drugs. I want a better life. They come to treatment. They can't sleep. They have no energy. They have no appetite. They can't focus. Like, oh, that doesn't sound like a great life, especially when your limbic system is perpetually reminding you that you could just go back and use and feel better than this. What about mortality rates? Mortality rates for patients with an opioid use disorder who pursue abstinence-based recovery is 10 times higher than those that get MOUD. And it should not be surprising that if you combine medication-assisted treatment with psychosocial treatment, it's superior to either one alone, right? This is what we do in medicine. If I'm diabetic and I go to my doctor, he's like, okay, here's your insulin, but I don't get any education or support, how well am I going to control my diabetes? Probably not very well. On the flip side of that, if they go in and they're like, okay, we're going to have you see a dietitian and a nutritionist, but they don't give me any meds, what's the likelihood I'm going to manage my sugars? Not very good. I need both, right? So when it comes to substance use disorders, we need both. I can't just prescribe meds, but people don't learn how to deal with their trauma or deal with their kids or figure out how to manage probation or parole. Like, I need my case managers, my nurses, my social workers, my LAC. I need everyone to help me make sure that people have all the tools. Because again, if we're looking at a pie, I can give them one piece of the pie, right? But they obviously, if you want a full pie, you have to have more tools. So what are the benefits? Well, opioid use disorder increases your risk of premature death tenfold compared to the general population, right? This is a very, very lethal illness. 1 in 20 people who survive an opioid overdose will die within a year. 20% die within the first month, which means if you take 20 people that overdose, one of them's going to be dead in a year, right? That's insane when you look at how young a lot of our overdose victims are. MOUD decreases overall mortality by at least 50%. At least 50%. So,
Dr. Hinkie, we have a question. Can you explain again, what does the naloxone do in the Suboxone?
Sure. Yes, I can. So there's this idea that the naloxone is in there to block other opiates, right? So if I'm taking my Suboxone, which is buprenorphine and naloxone, that if I take other substances on top of it, it's the naloxone that blocks it, and it isn't. The naloxone is a almost entirely deactivated in our mouths, right? So Suboxone is taken sublingually under your tongue. Most of that is deactivated, not even absorbed. The naloxone is only in there to prevent someone from shooting up their buprenorphine, right? So if I somehow dissolve my Suboxone tablet and I decide I'm going to inject it, I'm going to be giving myself IV Narcan because naloxone is Narcan. So that will immediately throw me into opioid withdrawal. So it is put in there as a diversion tactic. So one of the things that the DEA and the FDA did when we started down this road of the opioid epidemic is they tried to make things more difficult to abuse, right? So they tried to make it so that the chemical makeup of pills, it was harder to inject. They would turn into a gel. They would do all these weird things. And one of the things they did was add naloxone to it, because again, if you swallow it or dissolve in your mouth, the naloxone has no effect. It really only keeps it from being injected. So I hope that answers the question. Okay. So during the first 4 weeks of treatment, buprenorphine is associated with a 90% lower mortality rate. Methadone is associated with an 80% lower mortality rate. And after that first 4 weeks, 40% lower mortality rate. So again, like, I don't know about the rest of you, but I don't think any of us went into this business to help people die, right? The purpose was to help people survive. These are great tools to keep people alive. So even if someone comes in and they're started on buprenorphine and they don't make it, for whatever reason, their mortality rate still is decreased just by exposing them to the buprenorphine and the treatment that's associated with it. Interestingly enough, I talked about how difficult it is to dose methadone and the commitment it requires. When studies were done that looked at methadone versus buprenorphine, more people stayed with methadone, or they stayed with methadone longer than they did with buprenorphine, almost twice as long. Methadone, it's usually about a year. Buprenorphine is about half that. So again, it's a huge commitment, but I will tell you that and we have been doing Suboxone at Heartview since December of 2010. So a very long time. We've been doing methadone for about 5 years, maybe six. But one of the disadvantages to buprenorphine is there's a max dose. Like, you get to 24 milligrams a day, that is the max dose. So with fentanyl having the potency that it does, people that have been injecting fentanyl oftentimes will have difficulty stabilizing on buprenorphine. With methadone, we can titrate to effect. Like, we can titrate until they feel stable. So that may be why people stay with methadone a little bit longer, is that they actually, if you're a really heavy user and have high tolerance, they do feel a little more stable on methadone. So what about the incarcerated population? Well, 15 to 25% of incarcerated people in the US meet criteria for an opioid use disorder. We have successfully locked up a whole bunch of people with SUDs. Courts recently found that denial of MOUD to an incarcerated person with an OUD violates the 8th Amendment's ban on cruel and unusual punishment, and also likely amounts to discrimination under the Americans with Disabilities Act. So what does this mean? Well, this means that if you are on these meds and you go to jail or prison, you should be able to continue on these meds. So there's been a little bit of panic in our criminal justice system as they're trying to figure out what this means, right? Because if someone is stable on methadone and they're in the federal court system, which we know is very bogged down, and it might take them 2 years to get to trial. Well, at 2 years, they're 2 years stable and doing well and doing all the things, and then they get locked up and they lose their meds. They may have grounds for a lawsuit. Well, our DOJ doesn't want to be sued. So it basically means that we have to do things differently. We would never take away someone's insulin just because they're incarcerated, or stop their chemotherapy because they're incarcerated. So this has been an interesting change in the criminal justice system. So again, after incarceration, the risk of unnatural death was 87% lower for incarcerated people with MOUD compared to those without. Again, overdose, suicide, other preventable causes. In the month after release from incarceration, an individual is 56 to 129 times more likely to die of an overdose, depending on the study that you look at. Why that is again, we become incarcerated. That tolerance that I talked about, we lose, right? Because it's like, well, I'm not using anymore, so my tolerance drops. But when I come out, well, I used to inject half a gram of heroin, inject a half gram of heroin, and now it's laced with fentanyl. I don't survive that. So this is a very high risk population just coming out of incarceration. An MOUD reduces the risk of death from any cause by 85% and the risk of death from an overdose by 75% in the first 4 weeks. So again, dramatic improvements in life expectancy. So take home points. Addiction is a chronic relapsing disease of the brain. Doesn't matter what substance we're talking about, this is the illness we're talking about. Fentanyl is driving the overdose crisis. Recovery is an individual process. It may or may not include MOUD, right? That isn't for me to say. I have people that this is the only tool in their toolbox, and I have people that like use this for a short amount of time and they get all the rest of their tools and then they go out and they're successful. If you combine meds with psychosocial support, it is much more effective. This is a life-saving intervention. I mean, we talk about Narcan being life-saving, but utilizing these medications is life-saving, especially for our incarcerated population while they're incarcerated, but also upon their release. And again, how deep is the mud? It depends on who you ask. We all go through the same stuff differently, right? We may think that what we're going through is not a big deal, but to the next person, it might be really deep mud. So a little bit of compassion and understanding. Love, kindness, and empathy. The world is absolutely in short supply. One of my passions, my missions is trying to reduce stigma, because it is very easy to sit on our thrones and judge other people, but you have no idea what that person has gone through. And until we can have the conversations and realize this is an illness and it needs treatment, we're going to continue to lose 100,000 people a year. That is ridiculously unacceptable. Again, my girls are teenagers. One of them is looking at going to college next year, and I'm thinking, oh my gosh, they already know. They can name a handful of kids who have suicided in high school. We have a suicide epidemic. We have a substance use epidemic. We have all of these things that nobody wants to talk about. We want to talk about breast cancer and heart disease, and that's great that we talk about those things, but we need to talk about these things because this is what's really impacting our young people. So
my children at 22 and 19 have been to more funerals for peers than I have at 50.
It's just sad.
Yeah.
And it's almost like it's normal, like, oh yeah, another kid from such and such suicide. I'm like, what? How can life be so hard at 16? But again, when I was talking about how it's all drugs, it's not just opioids. I think some of that is because we have this idea that we shouldn't ever feel sad and we shouldn't ever have pain. And so we're always looking for something to make us feel better instead of teaching our kids how to cope. Life is hard sometimes, right? So we have to learn how to cope with being sad and cope with being heartbroken and cope with all of those things. And until we teach our kids how to do that, they're going to continue to look for other places where they can feel better. And that's not real feel better. That's unfortunately very, very fake and very tarnished. So I would love to field any questions. I'm going to check the chat box here. Oh gosh, I get to see where you're all from.
Yeah, we're all from. There was a question, I'm putting it in there right now. Where can one find this recording? So we are working on getting the recordings up on ND Train or Train ND, one of those. So we will have that shortly going. So other questions for Dr. Hinke? So
thanks, Morgan.
Yeah, thank you for sharing, Morgan. I actually, that is one of the things that I know you said that I hyped you up at the beginning, is that I do think that you do such a wonderful job of presenting it at the real world level. So in a way that makes sense and makes it really digestible. So question, Missy, can you present this to Tribal?
I will present this anywhere that I'm allowed. I talked to high school kids. I talked to HOSA. I talked to the medical association. I will talk to anyone that will listen. The nurse practitioners and the CAs. And I think in June, I'm presenting at Vision West, which is out in Dickinson, which is a movement out there to try to, improve mental health services. And again, I think so, and I have my own stigmas, right? I think that so much of how the stigma that we have, it can be combated with education, but we just have to be willing to listen. And so I think if people come to the table willing to listen, I think we can have dramatic progress.
So yeah, Morgan made a statement about it has helped me share more when questions come up in group sessions. Having a lot of clients that actually judge methadone. I really do think there is that it's still a large amount of stigma around the use of methadone and other medication assisted treatment, as far as that not being really in sobriety, that not being in recovery. And so I think the way that you explain it really provides that good information.
Thank you.
So yeah, it's great, Morgan, that you have that information now to give on.
Correct.
Now, I have a question along that line, and this isn't necessarily for you, but so are there materials geared towards that population? So geared towards like those in treatment around that, the stigma, and helping explain that it's not just substituting one addiction for another.
I don't know exactly. I mean, there's good resources out there like SAMHSA, Substance Abuse Mental Health. They have really good data on, stigma as well as just efficacy of medications. Recovery Reinvented sometimes has some good information. So yeah, I guess I don't. Drugabuse.gov. There's a lot of them if you just Google. I kind of get it from all over the place. And maybe if anyone else has a go-to source, I'd be happy to open the floor for that.
So here's a question. What is the trajectory desired for long-term methadone dosing? Is there an intention to taper clients off completely at some point, or is it all up to the client's desire and motivation? Essentially, is permanent dosing encouraged or discouraged?
So the data on MOUD is that, it is a long-term treatment, so can be lifelong. I generally, when people first come in, they're like, oh, hell, I only want to be on this 6 weeks. I'm like, okay, let's get you stable. Let's get you doing what you need to do. And then again, I just tell them, if your recovery pie is 90% methadone, you should probably stay on methadone. Same with Suboxone. If your pie is 5% methadone and you have all of these other great pieces, spirituality and pickleball club, and you go to church and you do the things and you have a sponsor and you have this great pie, absolutely. We can talk about coming off of that medication. Not everyone has a desire to really work a program. Some people have a desire to just not use drugs. And they don't necessarily want to, like, quote unquote, be in recovery. They don't want to go to meetings. They don't want to do the things. But that doesn't mean that they should die. So if this medication is a way for them to stop using drugs, and we can have those conversations about health and wellness and what does recovery look like and setting goals, then we do that. So it really is very individualized, and it really comes down to, what are your goals? If this isn't something you want to be on forever, great, we can have that conversation. But then I'm very frank with them about, you better do some work because your recovery pie needs to be a pie. And so, yeah, I see lots of people that come in and they're like, I don't want to be on this forever. And then, they're 3 months into it. They're like, I didn't know I was going to feel normal. Like I thought I was going to feel probably impaired, but I actually can hold down a job, and CPS says I'm gonna get my kids back, and I'm paying my bills, and I'm doing all these things. And so, I mean, I'll just stay on it for a while. And so we have that conversation intermittently, but it is meant to be a long-term, possibly lifelong treatment. I will tell you that people who ended up getting down this road of an OUD because of pain management issues often want to stay on it forever because they still have their pain. And so methadone is an effective pain medication. So is buprenorphine. So if they have underlying pain issues, we can do physical therapy and all those things, but a lot of times there is a need for some kind of a medication management there. So we think more long-term, but it really is up to the individual. And if they're doing the things, if they're continuing to drink and they're continuing to do all these other dangerous behaviors, we might not be able to stay on methadone or Suboxone, because there is a risk to combining benzos and alcohol and opiates with any of these medications. And so there is an expectation that you stop using some drugs. And if you can't do that and you're not willing to do treatment, it's a very individualized process, and it's different for everybody.
Somebody excited about Vision West in June. So.
I'm excited too.
So any other questions for Dr. Hinkie today?
Thank you guys for your attention. Appreciate it.
So yeah, thank you very much. So this is our series on kind of harm reduction and the kind of the overlap between behavioral health services and infectious disease. So today was very much around the harm reduction of, I think Dr. Hinkie really made the case that, this is a harm reduction strategy. This is a strategy that prevents, particularly around that overdose, and then also that more risky behavior use, those type of things. So I definitely think that those are important pieces. So our next session in this series will be March 29th, and that is the Words Matter session. That is really around all of the language that we use, particularly around behavioral health, and how that has changed. How now we do use, things like syringe services rather than needle exchange and that. And so really that's going to be our session on the 29th. So join us then. And then I really quick before, as piece of this, I could have done this sooner. Sorry, wasn't really paying attention. I am going to throw the post test in the chat and the evaluation in the chat. I will say that to make sure that you complete the evaluation, because that's what we do pull the, so that one right there is the post test. And then next I'm going to do the evaluation. So complete those in order to get your CEUs and CMEs. So, and then here is the evaluation. So any last questions? We've been really great, lots of information. So really appreciate that.